That be? Turns out pretty prevalent.
Very prevalent. Actually, when you looked at statistics, it is the third leading cancer in both men and women.
Wow.
You know, in men, prostate is number one, and a lot of things that don't get out there is prostate has the same incidence as men as breast in women. It's 1 in 8 men will get prostate cancer.
Mm-hmm.
Number 2 is lung in both. And then number 3 is colorectal cancer, being the third largest cancer in this country as far as incidence.
Probably a semi-accurate statement. You can tell me, you probably phrase it better than I. Colon cancer is as curable a cancer as there is.
Right. If we catch it early, you know, at a polyp stage, it can be cured in the vast majority of patients. You know, and the problem is that, you know, if you don't get screened, you won't find it, and then it presents at later stages. By the time you have symptoms, it's usually more advanced.
Yeah. Yeah. All right. So that makes screening very, very important, doesn't it?
Right. And, you know, colon cancer is also the number 2 cause of cancer deaths in this country. Lung being number 1, but colon cancer being number 2 when you combine men and women.
I bet you that's a surprise to a whole lot of people.
Yeah. And, you know, you wouldn't think that, you know, and this is for mostly a preventable cancer.
Yeah. All right. So we say screening, but there are more than one way to screen.
Absolutely. You know, the old fecal occult blood test, the finger wave, you know, or you would take a stool sample and put it on a card and send it in your doctor. Mm-hmm. Or when you go in for exam, he would do an exam, a rectal exam, and, you know, test the stool with a fecal occult blood test. That's a dye that, or a test that picks up blood in the stool. Mm-hmm. The problem with that is that not all cancers secrete blood in the stool, and it was not all that reliable.
Yeah.
So now we have better tests. You know, there's the FIT test, which is the fluorescent immune testing for blood in the stool. So that picks up more blood in the stool than just the regular old fecal occult test. Mm-hmm. However, still not that great. So the next one that came around is the Cologuard. And the Cologuard actually looks for DNA in the stool, cancer DNA in the stool. Far more accurate than either of the blood tests that are out there. You know, that's the box commercial you see on TV.
Sure,
nowadays.
the walking box.
Right. And it's actually very good. It's had a significant increase in people getting screened, so that's a good thing. It's not as good as colonoscopy. And there's a high, not a high, but there's a significant number of false negatives because, again, not all cancers are shedding DNA all the time in the stool. And guess what? If you have a positive Cologuard or fecal occult blood test, the answer is you need a colonoscopy.
Yeah.
And colonoscopy is still considered the gold standard for screening. The others are supplements to colonoscopy.
All right. So the colonoscopy process, let's grant that it's not the most comfortable process in the world, but generally that's just the prep stage, right?
Right. And the preps have gotten better. Mm-hmm. You know, it used to be horrible, you know, but some of the preps have gotten better. And that's the worst part of it is, you know, you have to cleanse your bowels. You know, people pay money to have a bowel cleansing, you know, and so it's, you get a bowel cleansing for your colonoscopy.
It's a perspective.
That's right. But, you know, the intestines lining have to be clear so you can see polyps. Yeah. And if we can go in and see a polyp, we can remove it and thereby preventing a cancer.
Mm-hmm. Now, when we think about polyps, that's a word that has a certain connotation in our minds. We can sort of picture a little lump. Mm-hmm. Is that the best way to term that?
Well, there's 2 different types of polyps, or actually more than that, but the 2 different types of precancerous polyps. One, I would say it grows like a mushroom. You know, it has a stalk on it and then has a broader head on it. And that's an adenomatous polyp, and that, you know, can be easily snared and removed on a colonoscopy and prevent a cancer. The other one is a tubulovillous polyp that grows, I would say, like a shag carpeting, if you remember the 70s and the shag carpeting. You know, it doesn't have a stalk. It actually grows along the lining of the colon. Mm-hmm. And those are the 2 most concerning polyps that are precancerous.
Mm-hmm. Now, when you say precancerous, that implies that when you remove them, you remove the chance of them developing into cancer.
That's right. If you can remove the polyp, you've removed the risk of cancer.
Just that simple.
Right. And the really worrisome thing about screening right now is that our incidence of, or our death rate, mortality rate for colon cancer in people over the age of 50 has decreased about 1% per year for the past 10 years. And that's because of increased screening. The concerning thing is we're finding more and more colon cancers in younger people in this country. And the incidence of colon cancer in people between the ages of 45 to 50 have increased by over 10% in the last 10 years. And the unfortunate thing is that without screening, this is not a population that we had recommended screening for. They're coming in at more advanced stages. And the mortality or death rate from cancer in younger people is higher than those in older people because of the stage we're finding them at.
That being the case, has the recommendation changed now for when someone should have their first colonoscopy?
Absolutely. And a few years back, the American Cancer Society changed their recommendations to age 45 for average risk people. That means you have no family history of colon cancer, you have no symptoms. It used to be at age 50 you should get your first colonoscopy, and if you're clean, you wait till 60. You can go another 10 years. Now it's age 45, and that's with no family history, no risk factors. So the average individual should have a colonoscopy at age 45. If you have a family history of colon cancer, you should have it at least 10 years younger than the youngest person in the family with colon cancer, or by age 40, whichever comes sooner. Mm-hmm. So if your father had colon cancer at 55, you should have a colonoscopy at age 40, not 45.
Yeah, well, and that makes a tremendous difference in your ability to catch the disease and eliminate it.
Right, and like breast cancer, we're seeing it in younger women. We're seeing colon cancer in younger men and women in this country. There's a lot of reasons for that. The risk factors for colon cancer, some of them we can control. Obesity is a big risk factor for colon cancer. Inactivity. Diet high in red meats and processed foods like hot dogs and lunch meat. And, Pennsylvania, I'm from around Philly initially, we like our hoagies back in Philly, and here, they're subs. Mm-hmm. And so, that's processed meat. And I like a good sub or hoagie every now and then, but you've got to limit that amount of red meat and processed food in your diet as well.
Yeah. I know Dr. Billen is highly recommending the Mediterranean diet, and there are certain elements of any diet plan that can help you in terms of your overall physical well-being, and just as there are certain elements of any diet that can really increase your risk. Right. And those red meats can really be a factor in colon cancer, can they not?
Absolutely. And, everything in moderation is the answer. It's not like you have to strictly not have any red meat at all, but limit it to maybe once a week, or something like that. And alcohol intake is another one. Excess alcohol intake, which is considered greater than 1 drink per day, increases your colon cancer risk. And I know Dr. Billen's really up on the Mediterranean diet, and actually there was a review of all diets for overall health benefits lately, and I saw this on the Today Show. And the Mediterranean diet came out number 1 for benefits for weight maintenance, for cancer, for all types of things. So the Mediterranean diet is considered the best diet out there as far as limiting your risk for cancer as well.
Yeah. So those are steps to help prevent developing colon cancer, and there still is going to be a certain percentage of folks who are going to develop it anyway,
right?
Who don't follow those steps, or who just, because of one factor or another, end up with colon cancer.
Right.
Tell me about the treatment.
Well, the treatment nowadays has gotten a lot better. If they do a colonoscopy and they find a cancer just in the tip of the polyp, we call that in situ, it hasn't invaded into the colon wall or anything like that. Sometimes just the polypectomy is enough. Most of the time, that's not the way they find it, and it's a little more invasive than that. It's headed down that stalk, or it's into the colon lining, and then it has to be removed surgically. Mm-hmm. And in the old days, we call it now, it used to be an open incision, and you'd go in and you'd spend anywhere from 7 to 10 days, sometimes up to 2 weeks, recovering from that operation. Because with a big open incision and going in and removing a section of your colon, your entire intestines shut down, you can't eat for a while, you're on IV fluids. They used to put a tube down your nose, which we no longer do, even with open surgery, for colon cancer. But it was a long, prolonged stay in the hospital and a prolonged recovery. And if you have a larger wound, there's a higher risk of wound problems as well. Then we went to laparoscopic, which is the small incisions like gallbladder. And you go in with several small incisions, but you have straight instruments. And, I always say, I heard one of the gynecologists talk about it's like tying your shoelaces with long sticks, because they don't bend or anything like that. The instruments, the tips just spin. But that was a significant improvement and improved our stays in the hospital down to an average of 5 to 7 days. Now we have robotics, and I've been doing robotics. This is my 15th year of doing colorectal surgery robotically, and it's just an amazing advance. It's still laparoscopic or minimally invasive with the small little incisions, but now we have full dexterity. You have wristed instruments. You have full wristed manipulation in there. It's like having little hands in there. And on top of that, you have a camera for each eye. So now you get binocular vision back. So instead of looking up at a screen, working on high flat panel, but high def, you're working now with full depth perception, 100% 3D, and you can zoom in up to 10 times the naked eye.
Yeah. And at IRMC, robotic surgery has advanced so much, you actually had to add a second unit, didn't you?
That's right. Yeah, we're considered one of the leaders in Western PA in robotic surgery. When I first got here 5.5 years ago now, we were the fastest growing robotic program in the country, in the tri-state region, Western PA, all of West Virginia, and Eastern Ohio. That includes the city. And so, yes, and within 2 years of my arrival, our robotics program had increased so much we needed to expand to a second robot.
And because of that, of course, that demands folks who are trained on it and better teams of people who are constantly working with that equipment. The doctors all go through the very rigorous training. And what it ends up being is a whole team of experts that can robotically take, in this case, colon cancer and really, really improve your odds and your recovery time, as you've said.
Absolutely. Our OR team is outstanding. The robot is no longer, oh my God, it's the robot. It's this. What are we going to do with this? It's a routine. Our team is just so well trained, and we have such a well-oiled instrument over there of robotics in the operating room, from the nurses to the OR techs, anesthesia, because it's a different anesthetic. You don't give as much fluids for robotic surgery because we don't lose as much fluids without having open surgery. And we have early recovery programs afterwards, get people up and moving right away. We can feed you right away after robotic surgery because your intestines don't shut down. The nurses on the floor, they're all trained in the recovery after robotics. We have a fantastic nursing crew over on the floor as well. They get our patients up right away. They understand. We use a lot of non-narcotic pain medication, which is actually more effective than morphine, and that's what people don't realize too.
So colon cancer is extremely dangerous. It's very deadly, but it's extremely treatable and preventable. Absolutely.
If you get out there and get your colonoscopy, and then you can supplement that in the interims with the other tests, the Cologuard and such. And if Cologuard's great. If you don't want to have a colonoscopy, you get your Cologuard. But realize that there are some false negatives with the Cologuard, and it's not 100% accurate, and the best test is the colonoscopy.
Step up and make it happen.
Right.
Yeah. Really quickly, I only have a couple of seconds left. How often for the colonoscopy?
Depends on the findings. You start average at age 45. If it's negative, you can go another 10 years, so not till 55. If they find a polyp, depends on the type of polyp, and that would be 1 to 3 years later to have a repeat colonoscopy.
He's Dr. Dan Clark. Thanks so much for coming in. We appreciate it.
No, I'd love to be here.
You're going to be back later this week. We'll have the others on as well to help us, not this week, later this month, to help explain the colorectal cancer and how it is that we can fight it and beat it. It is Indiana in the Morning. Fox News next at the top of the hour.